what a fantastic gathering, an annual gathering, and what a great effort putting this together. And thank you all for being here. Couldn't be happier. I was sort of reflecting on what my dress attire should be today in California, and that's always it's usually an easy decision, right? So you just get out of bed and you scramble in with casuals, but I was very deliberate in my dressing choices today. Normally I don't attire with a tie, I'm usually pretty cash, but I said I must attire with a tie to honor all of you here, for one, and secondly, to sort of set myself apart so that people can find me. But I was pleasantly surprised to note that many of you are formally attired here in California, so go figure. I'm also from MAGA country, by the way, but we won't go there. But part of the goal, in all seriousness, is when we're talking about environmental exposures and things like climate. It's a very politically charged environment, and I have to say, in having done this for many years, that the path for healthcare practitioners is to go with the evidence and get everybody on board. You know, people who don't believe in the science, people who don't believe in the fact that environmental exposures might be a problem, lead with the evidence, show people the evidence, and serve as a bridge to convert minds and hearts, which is really part of the mission of the Save the Heart Foundation, is to really convert, people's practices to healthy dietary offerings, to risk factor control, and what we do in prevention. So this is all fundamentally important to us. And as healthcare practitioners, the only way to do this is to stay apolitical and present the evidence and hopefully convince people to recognize that this is indeed a major problem. Okay, terrific. I might actually look at the screen sometimes, so I'm sorry, I'd like to ambulate around the podium because I have a lot of nervous energy, but I'll try to restrain myself today and speak closely to the microphone because there's a live audience as well, right, following this. So I'm going to be very careful and stay restricted to this area. So let me present two patient vignettes, and this really is hopefully hits home for a lot of you, right? So this is a 64-year-old retired architect with prior coronary artery disease and a remote LAD stent who began his day as usual, coffee in his balcony overlooking the ocean. He lives in Pacific Palisades. But today the horizon was obscured by wildfire smoke. And you can check the date, January 15, 2025. Ash coating his railing. The air smells metallic. AQI of 268. I'm sure all of you in California probably look at the AQI once in a while, just checking in, right? So by late afternoon, chest pain begins. He has an inferior STEMI. And I recognize that a lot of you are also, some of you are the lay audience, so please forgive me. Some of the slides might be technical, but I'd really try to make this pretty simple so that you can follow along. So he develops a heart attack, an inferior heart attack, and because of plaque rupture, and goes to a cath lab and gets taken care of. A second scenario, this is an 81-year-old woman who lives in Venice, Oakwood, Venice, and she lives in a very small apartment in a very dense, crowded, low-income neighborhood. She's got type 2 diabetes, she's got coronary artery disease, hypertension, prior heart failure, relies on Social Security, keeps her windows open, has no air filtration, right? And this is the other reality of Southern California, right? As it is for many parts of the US, there's tremendous disparities in not only exposures, but also socioeconomic status. And that's a very important, as we all know, and as we'll discuss later on, socioeconomic status and where you are and what access you have, it's a major determinant of healthcare in the United States. Anyways, this was Jan 20th. She becomes confused. She develops chest pain. Unfortunately, she lives alone, and she does not call for help. Her relative finds her the next morning, and unfortunately, she expires, and she's found dead on arrival. So 2 different scenarios, and we'll explore this through the lens of what I'm about to present to you. The focus here is air pollution, but again, I'm going to weave in a lot of evidence from other environmental exposures that might be important. Now, I like to present this in front of cardiologists, and it's very apropos for a lay audience as well, so that you know what we do in cardiology. And I often say this I actually borrowed from my good friend who's an imager, Jim Min, who's always said, as cardiologists, we ask the right questions in the wrong order, right? And what does he mean by that? Well, in the 1970s, And Dr. Weinberg is here, Nicole's dad, who's actually a very respected member of the cardiology community. And he can tell you that back in the 70s, people were studying heart attacks and trying to figure out, what do you do about it? Do you keep people in the ICUs? How do you treat heart attacks? How do you treat rhythm disturbances, arrhythmias? And then they started focusing on ischemia, which is the blockage, and the blockage reduces blood flow, and that was a paradigm. And people focused on really trying to understand ischemia, so the consequences of low blood flow, right? That was the preoccupation, I would say, in the 1980s. And then people started focusing on, well, it's the ischemia, but let's really talk about the blockage. Let's figure out what's going on in the blockage, and that's what we call atherosclerosis, right? What is the biology of atherosclerosis? What happens? Do you have inflammation? All that stuff. So that's called atherosclerosis. That was a preoccupation in the 80s and 90s. But along the line, people were starting to think about risk factors. What really causes this in the first place? Let's go a little bit more proximate. Is it hypertension? Is it diabetes? Is it lack of physical activity? So you see that. So this is sort of the pyramid. But it's taken a while for us to zoom out a little bit and start thinking about what are the risk factors that are driving the pathogenesis of atherosclerosis that causes ischemia and heart attacks in the first place. And logical arguments, logical reasoning would predicate that you would sort of look at the proximate risk factors, because that's probably a much more effective way of dealing with the problem in the first place, not downstream when the person's already had the heart attack, right? But now we're focusing on things like lifespan. How do you keep people alive longer? And we've, in fact, migrated from just thinking about chronology and thinking about how long to keep people alive, because keeping people alive in a nursing home till you're 95, it makes no sense, right? So let's talk about health span. How do you keep people functionally active and healthy, right? And that's a preoccupation in California. A lot of longevity clinics, as it is in many parts of the US, actually, people are focusing on treatments that might increase healthy longevity, right? So unfortunately, we have a medical system that rewards the wrong behaviors. These are called perverse incentives. And I have this thing on the left side that shows interventions that are high cost, high risk, and low cost, that could be low cost, that are primordial prevention techniques, where you're thinking it. And I think people are starting to think about this, quite frankly, where how do we have a health system that's going berserk, inordinately expensive, and what do you do about reducing costs? And maybe focusing on the primordial risk factors and rewarding the right type of preventive behaviors, and I know a lot of you are interested in prevention, is probably the right thing to do. It costs less, it saves money, and is a more primordial, proximate argument for preventing health. So we've taken the view that maybe, and I certainly like to think, that we are starting to really enter a new era in preventive cardiology, where we are examining health and health span from a wide-angle lens, where we're starting to look at larger factors, primordial risk factors, and the environment is a big part of it. You see this. You have the national environment, the personal environment, the social environment, and things like toxic exposures that might predispose you to things like stroke, heart attacks, etc. So here's a footprint of pollution in what I'd like to call, and this is a terminology that was coined many years ago by a Nobel Prize-winning scientist called Anthropocene era, which refers to all types of exposures that are the consequence of human activities, right? So a conservative estimate of this is that environmental toxic exposures in particular result in 8.1 million deaths. It's the second leading cause of mortality globally, and it's really an underestimate. Some people say 12 million, but as I'll show you, environmental exposures are often hidden, and it's very hard to quantify what is an environmental exposure. And as I'll show you, many of these exposures take decades, right? Years to manifest. And clearly, when somebody has a heart attack, you don't have something on their forehead that says this is because of environmental exposures. It's very hard to attribute an event due to an environmental exposure. And that's what we call an attribution problem, where you can't really say for certain that certain events are related to toxic exposures. And this long delay or latency period is a big part of it because it takes literally decades for this to happen. So how do you figure this out? It's an emerging science. And what you're seeing here is likely environmental exposure is probably the leading cause of global mortality and morbidity, but what we have is an underestimate. And this is a very closely interconnected set of drivers, as you can see here, because it all starts with fossil fuels. Now, fossil fuels are there for a reason too. They've made modern civilization possible in many ways, right? But we're also in an era of transformation, where there are other alternatives that are possible that could be better, that could lower the use of fossil fuel usage that drives a lot of these things. So air pollution being one of them, but related to it is water pollution, soil pollution, synthetic fertilizers. We talked about plastics, a lot of the chemicals that come out of these petrochemicals. So this is a massive driver of exposures. And we'll talk about that in just a second. And it turns out that the vast majority of health events, be it strokes, heart attacks, hospitalizations, relate to cardiovascular events. The primary reason people die of air pollution is not lung cancer, it's not asthma, it's heart attacks, strokes, and deaths related to heart problems, right? So that we know for a fact. So the vast majority of deaths, and that's also true for other environmental exposures. It turns out that many of the exposures work along very common pathways that lead to an excess of cardiovascular events. And it turns out that cardiovascular events are the leading cause of global mortality. People die more often because of heart attacks or strokes than they do because of cancer. Not that cancers are not important, clearly, but as if you count numbers, they numerically pose a larger problem than cancers do. Now, when we talk about air pollution, and going back to our patient vignettes, we are talking about particles that are less than 2.5 microns. These are called PM 2.5 particles. There are also smaller particles or ultrafine particles that can penetrate the lungs, enter the circulation, enter your brain, and cause a lot of problems. Of all of the components, now air pollution is a very complex mixture of chemicals, lots of different things, and it also changes in chemistry as it reacts with other components, with sunlight, a lot of things that happen. You're familiar with ozone. But of all of the things that you could say, if you ask me what is one thing in air pollution that causes health problems, it's PM 2.5. And it's a very simply calculated component. You don't need sophisticated equipment. You can have a purple air monitor or a monitor in your home. It'll give you a readout of what your PM 2.5 levels are. So it becomes very easy to deploy. It's recognizable, something that you can measure very easily and consistently associated with epidemiology. Now, this has been something, wildfires have sort of emerged as a problem within the last 10 years, and nobody could have predicted this, right? Before 2017, if you said to me or anybody, people studying this area, that wildfires could be a problem, I would have said, I don't know what you're talking about. But since 2017, there's been a huge surge in the number of wildfires in the United States, but also in the rest of the world. It's a massive global problem. And this slide depicts a paper in Nature that came out in 2020, I think 2023, so it's been a while. So what they did was they tracked all of the states within the continental United States to look at which states are actually showing increases in air pollution. And you see that very complex slide there. But what this is showing you is typically, thanks to air pollution regulation, and California has been at the forefront of air pollution regulation. So congrats to all of you that live here, because you've made substantial contributions to changing the climate and the heat, no pun intended, and the politics of air pollution. You said California stands apart. So it's been at the forefront. But thanks to air pollution regulation in this country since the 1970s, air pollution levels have dramatically lowered, right? So it's been, we have pretty clean blue skies and clean air in most of the country, most of the country, in California included. But since 2017, there's been a shift. There have been states, and you can see this, where wildfires have influenced stagnation, which means that air pollution levels, as opposed to progressive decline, are now stagnant. Okay? And there are some states in purple, you can see on the right side, where wildfires have actually increased air pollution levels, right? So what you're seeing is a reversal of a trend where air pollution levels were dramatically declining and continuing to decline. And since 2017, there's been a shift thanks to wildfires. Nobody could have predicted this, several years ago. And as I said to you, this is just not a US phenomenon, it's a global phenomenon. Now, globally now, wildfires within the last 10 years kill as much as malaria and HIV globally, right? 1.53 million lives every year. And you can see this, you can't read the text at the bottom, but I wanted to show that because the vast majority of these deaths globally are because of cardiovascular reasons. Okay, now what do we know about the biology and the mechanisms by which pollution causes heart attacks? And this is just a cartoon here. And just to drive home the fact that these exposures, there is an acute phenomenon, and I showed you those patient vignettes where there's a sudden spike in air pollution, and it often tends to affect individuals or patients who have prior disease. And those are the two vignettes. You had one individual very wealthy, but nonetheless was living in a wealthy part of California, but had risk factors. And the other spectrum was an infirm, older individual with prior risk factors, including diabetes, a lot of other problems. So there's certainly that. So in this slide shows you a sudden blip in air pollution level. So you can see air pollution levels here. This is the air pollution levels on the y-axis, and you can see this black line showing progressive decline over many decades. And this could be the United States, actually. Now air pollution levels start to go up. And then within this little increase, there's a blip, there's an acute. These are all averages, you see. So there's a lot of, this going on because an average is an average. So you can see a sudden increase in air pollution spike, and as a consequence, somebody could have a heart attack. And you can see a plaque build up here. So there are two things going on here. There's a long-term exposure to air pollution level over many, many decades that plays a role in causing some of the risk factors. And I'll show you data that air pollution can cause an increased blood pressure, can cause diabetes, insulin resistance, even Alzheimer's disease, right? So it's a toxin. But at the same time, there's also an acute phenomenon so there's a chronic biology and there's an acute biology to how these events occur. And this is what hopefully this graphic depicts. This is some data from calcium scoring data. This is a colleague of mine, Dr. Joel Kaufman, who studied calcium scoring in response to air pollution and showed that there is indeed a relationship between exposure, higher levels of air pollution, and higher levels of calcium. So higher levels of calcium are a surrogate for atherosclerosis, this disease that causes heart attacks in the first place. So showing an association between air pollution metrics and calcium scoring is suggesting that it's indeed involved in the biology of atherosclerosis. So this is what we think are mechanisms. Now, there are a few other things, and you can ignore this, but essentially those of us who study this know that things like oxidative stress, endothelial dysfunction, autonomic imbalance, plaque instability, increased thickening of the blood, or what we call thrombogenicity, can all result in heart attacks. And there's indeed good data suggesting this. Now, I wanted to show this because this is just not a US phenomenon, as I mentioned. This is data from China. This is involving 8.8 million admissions. And you can see little dots here. And you can see, and the little dots actually reflect higher levels of wildfire episodes. So you see it's a nationwide phenomenon, except perhaps if you go in the western part of China. But these are higher levels of exposure. And what it translates into is that 1 microgram of PM2.5 can result in a 0.16 increase in cardiovascular disease, 0.28% increase in ischemic heart disease. And look, you could look at this and go, well, this is a very small thing. But if you put the population together of a massive country like China, this turns out to be a pretty big number, right? So this is what this shows. I'll leave that. And now there are other mechanisms, and we'll skip this for a reason, because I think hopefully by this time, I've convinced you that there is a relationship between air pollution and cardiovascular events. I've also shown you data that wildfires can indeed influence your risk for heart attack. So I'll leave you with that. It's a little complicated. Those of you at the back might not be able to see this, but I'll walk you through this. This slide depicts the amount of blood pressure globally that could be related to elevated levels of air pollution. And the slide depicts areas of the world where air pollution is really a problem, like India, China, for instance, parts of the Middle East and Africa, where air pollution levels are much higher than you can imagine in this part of the world. And in those countries, a substantial portion of blood pressure, and those of you who are familiar with blood pressure know that you measure this in millimeters of mercury. And it turns out that even small elevations in blood pressure, a 2 millimeter elevation, can translate into an increase in heart attacks and stroke. So 2 millimeter increase translates into an 8% increase in major adverse cardiovascular events, so heart attack, stroke, and death, right? So 2 millimeter, 8% increase. Well, it turns out that some of the air pollution contributes in some locations to almost 4.4 millimeter mercury increases in blood pressure, right? And this is the rest of the world here, many parts of the world where you have 2 to 4 millimeter increases. And that's not trivial. So at a global scale, you see a phenomenon where elevated blood pressures can relate to an environmental exposure. So, and this is some of the math. I'll just leave you with that. But just the idea that a risk factor can have its origin in environmental exposures might be pretty interesting and new to some of you, right? And this is diabetes. I'll just say that there's plenty of evidence suggesting that air pollution exposure can do all of these things, including skeletal muscle insulin tolerance, liver fat accumulation, adipose inflammation or fat inflammation, immune system dysregulation, a lot of these things. And globally, 20% of diabetes-related deaths could be related to air pollution. And again, these are high exposure areas. So there are parts of the world the air pollution levels are high, population levels are high. So the impact on a large population can be substantial. Now, we'll get to metal exposures now in a second. So the whole range of metals that we are exposed to. I would say that the most important sources of exposures are depicted in the right. So 3 metals: lead, arsenic, and cadmium. So there are other metals too. There's certainly mercury exposures. But if you ask me currently, doctor, tell me which metals are probably the most important that I should be concerned about, those are the 3. You can see the sources of exposure. Cadmium exposure, as many of you might not know, actually originates in the soil. Smoking can give you cadmium exposures, but there's also green leafy vegetables that have cadmium in them, and you would never suspect this. And why? Because fertilizers, synthetic fertilizers that are used to fertilize soils where green leafy vegetables in California are grown, may have higher levels of cadmium. They're trapped in the leaf, in the body of the plant, and therefore you might get high levels of cadmium exposure. Arsenic, I'll tell you about arsenic exposures. Now, these are absorbed by the gut predominantly. Lead, for instance, lingers around for a long time. It concentrates in your bones. So bone specimens are actually pretty good ways of quantifying lead exposure in somebody. Of course, you don't do bone biopsies, but you can actually do autopsies on people and get a good estimate of what the lead exposure might have been 1,000 years ago, for instance, during the Roman civilization. It's very interesting, experiments like that. So the point is that these 3 exposures are associated with cardiovascular events, heart attack, stroke, and peripheral arterial disease. Now, arsenic in the US is a problem. I don't know how many of you know that arsenic could be a problem in the US. Okay, some of you. How about lead? Yeah, a lot of you are familiar with lead. So arsenic is a problem, especially in the southwestern United States, right? So groundwater, as you can see here, and this is a heat map showing you the areas in red and orange are particularly concerning, and yellow, and most of those are in the western United States, right? And there are many parts of the US that rely on groundwater, so it's probably a good idea to check whether you're being exposed continually at high levels of arsenic. Community water systems also have high levels, and this you can again see the mid part of the United States and the western part of the US are high levels of arsenic exposure. Now, arsenic exposure is very strongly associated with cardiovascular disease, no controversy. And this is some data from cardiovascular disease from Strong Heart, which is a very large epidemiological survey analysis, and looking at, and you see those lines going up, it means that higher levels of arsenic exposure in your urine. You can easily measure arsenic in the urine as an exposure, and that correlates with cardiovascular mortality. What about lead? Now, these are 2 very interesting experiments, okay? On the left is an experiment done in Dunedin in New Zealand, where they took about 565 young children at the age of 11 in the 1970s, okay, and happened to have their blood samples. So they measured lead levels at that time. And you can see at the bottom, the mean lead levels are about 11. In the US, mean lead levels have come down dramatically since the 1970s because of regulation, right? So lead levels have come down. Why? Because usage of not using lead pipes, petroleum, that had lead additions as an anti-knocking agent. That went away in the early 1970s, so we're not exposed as much. But back then, you can see what the impact is. These children on the left side were followed in Dunedin, in New Zealand, were followed over 4 decades. And they measured serial IQ tests on them. And one of the most important, horrific associations of lead exposure is the effect in cognition in children. Horrific. And you can see, and this has been shown many, many times, you can see that the change in these kids over 4 decades on their IQ is dramatic. And not only that, it was a very important predictor of where they wind up in society in terms of their socio-environmental, social-economic status, not socio-environmental, socio-economic status. So where they wind up, which is obviously related to cognitive skills, was not in a good place after these exposures. On the right side is a very interesting experiment done by Bruce Lanphier, who's a very famous epidemiologist, looking at lead exposures in this country. And people thought that, you don't really have to worry about low lead exposures because it's really a problem only when lead exposures are very high that you get these issues, like greater than 10, right? Number 10. But what Bruce shows, and you can see this here, on the and you can see the x-axis here where it shows you lead levels of 2.55, 7.5, 10, right? And you can see this relationship. And on the y-axis is what we call hazard ratio. Hazard ratio is your risk for having, this is looking at mortality. I think this is actually cardiovascular mortality, heart attack mortality, dying from a heart attack, right? And what this is showing you is your risk for dying from a heart attack. And you can see this continuous relationship to levels even lower than 5 microgram per DL. So that shows you even low levels of exposure are associated with a risk for heart attack and total deaths. And the slide at the bottom, the figure at the bottom, shows you that concentrations of high lead in the blood contribute to roughly 400,000 deaths a year in the US. It's almost comparable to the number of deaths a year because of smoking. Now look at that. Much higher than what you would anticipate even with physical. So physical activity is protective, which is why it's blue. And alcohol consumption is more than 4 drinks a month and shows you, alcohol is protective. But nevertheless, hypertension here is, we won't go there today, so maybe another discussion. So, all right, hypertension is here. This is an older paper, but nevertheless, you can see that the relationship is pretty dramatic, just to drive home the point that lead exposures are a major cause of annual deaths in this country, okay? All right, now what about plastics? Now this is a big, hot area. Everybody's interested in plastics, right? So, and this is, the problem is the plastics are ubiquitous. I mean, it's so pervasive and so inescapable. It's one hallmark of anthropogenic activity is plastic. So it's penetrated more than 1,300 aquatic species and terrestrial species. Not a single species, I think, that we are aware of that don't have plastic in their bodies, right? And every part of the environment, be it the Antarctic or Mount Everest, is plastic, so that shows that. So it's everywhere. And it comes in different flavors, obviously. We are interested as doctors and physician assistants and folks interested in healthcare in the microplastics and the nanoplastics. So microplastics are plastic less than 5 millimeters. Nanoplastics are those which are less than 1 micrometer. And why are we interested in size? Because those are they penetrate your human body easily. They absorb, they travel, et cetera, et cetera. Now, it turns out that plastics, when they undergo degradation in the environment, when you expose plastics to natural elements, and they are sort of weathered plastics, hanging around on the beach for years, for decades sometimes, the plastics undergo chemical and physical transformation. And it's only then that the structure, biochemically, the structure of the plastic is opened up, and that's when it gets degraded, and those types of plastics are deleterious. So, and this is again emerging science. We don't know all the details, but to the best of our knowledge, it's degraded plastics that undergoes chemical, physical transformation, weathering in the environment that's responsible for, and it penetrates your ecosystem, right? So if you have beaches with plastics that are undergoing degradation, they contaminate your water, they're in your atmosphere, they're taken up by plants even, just like cadmium is. So they penetrate the ecosystem, and you're getting it to the air, you're consuming it in your foods, and you're drinking it in your water, oftentimes. But there's still a controversy about whether the fresh plastics that come out of your water bottles, for instance, is it really toxic to you? I don't know. We don't know that yet. But this is a simple experiment that I happened to be involved with. I didn't design the paper. I happened to be part of it in terms of, designing the protocol and helping with the analysis. But these were colleagues in Italy that did this experiment in Naples, 304 patients who they were having surgery done on their carotid arteries, and people have this surgery when they have blockages. They go back, the surgeons open up the artery and they remove the plaque, essentially. It's called a carotid endarterectomy. And they did the surgery, and they used this as a clever experiment to figure out whether the plaque actually contains microplastics. So this is the design of the study, 304 patients. What they found was very surprising. They found components like polyethylene and polyvinyl chloride in about 70% of their cases, right? So 58% had polyethylene and about 12% had polyvinyl chloride. And when they looked at this in electron microscopy, many of them had these jagged appearance. You can see that here. And this often activates a lot of inflammation and creates inflammation within the plaque. So it's a smoking gun. We don't know that. But when they followed these patients over time, these patients who had higher levels of plastic, and this again is showing you this relationship. On the y-axis is incidence of heart attack, stroke, or death. So the higher, the more the events, the lower events. So people who had more microplastics had higher events compared to no microplastics. Now again, this is these experiments are hard to do. How do you really figure out whether plastics are associated with heart attacks and strokes? And people have criticized this because there's a lot of what we call confounding factors. Because you could say, well, the folks who were having higher levels of plastics might be doing other bad things anyways, right? Maybe they had higher levels of exposures, higher levels of adverse activity. They were doing, lots of bad things they were not supposed to do. And maybe that's the reason why, and the plastics are innocent bystanders. But my argument is quite simple, right? My argument is if plastics are hanging around in parts of your body and you think they're innocent, that doesn't make sense to me. It doesn't follow the sniff test of, this doesn't seem right to me, right? And then you have these jagged microparticles, you're associated with inflammation. So it's more than a smoking gun. But I will tell you that the science in this area needs to evolve. There's not an organ in the body that I'm aware of where they haven't found microplastics. There are studies showing in brains, obviously, high concentrations, in liver tissue, in the heart, so many parts in the embryo, in the reproductive organs, everywhere. The question is, what are they doing there, and is it really harmful? And I would like to think that they're not just innocent bystanders. There's no such thing. There's no entity that I know that are just hanging out there and not doing anything to you in large concentrations. So we do have a lot of gaps in this area. There's also a substantial degree of controversy in the quantification of these chemicals. So a lot of the antagonists, folks in the petrochemical industry would say, and this is often, there's a whole lobby group, right, that comes out and says, you don't know what you're doing because you're not measuring it correctly, because the very test tubes that you collected your blood samples in is contaminated with plastics. So, this is your experiments are null and void. So a lot of technical difficulties associated with measurement of the plastic. So the current unknowns are really standardized methodologies. You also have to figure out dose response relationships. So typically in environmental exposures, you have to develop these very sophisticated ways of cause and effect. And that involves doing animal experiments, human epidemiology, putting all the evidence together. These are complex things. So it's not easy to kind of, I guess, peel the onion, shall we say. So there's a bridge, a chasm between causality and mechanisms, and certainly this has created problems for regulatory frameworks and policy because there's a big lobby group. It's a huge lobby group. I mean, think about it. It's the biggest oil manufacturers in the world, right? I mean, they're not just going to walk away and say, well, stop plastics. So this has resulted in problems with policy, in particular the Global Plastics Treaty, which would have been fantastic because in my neck of the woods, I'm going, well, look, there are parts of the economy and certainly parts of medicine that wouldn't be possible without plastics. Let's be real, right? Well, we got to use plastics there, no problem. But do we need single-use plastics? Do we need these plastic bags? Can we do away with some of these things? Heck yeah, we can, right? So it's a very simple argument where use plastics where you need to and get away and come up with alternatives where you don't have to use plastics. And that would be great for health, fundamentally centered around health, but also good for, for the economy in many ways because it stimulates other ways of thinking about the environment, coming up with better ways, better technologies, what I like to call green technologies that are more health-centric. All right, enough on that. So now let's move to diet exposures. Okay, this is massive, right? I can't finish a talk on environmental exposures, toxic exposures without talking about diet because this is fundamentally the most important lever to optimize human health and environmental contamination. It's massive. Now, I often, depending on the audience, I sort of do a little trick. Since I'm in California, I think I'm in friendly territory, so I can talk about climate and things like this. So usually when I'm in Ohio, I hide this slide and put this away. Because my goal is to build bridges. My goal is not to alienate, folks that don't believe in the science, but to lead with evidence. So this is actually a friendly audience, so I'm going to show you this. So on the x-axis is risk for mortality. So here is risk for mortality. And the y-axis is average environmental impact. What do I mean by that? Well, the paper, they looked at the environmental impact on a particular food source. How does it affect the water? How does it affect soil? How does it affect environmental degradation in general, right? So what they did was to put together a group of foods, and they said, anything on this side of 1 is good for you from a cardiovascular health perspective, actually from a mortality perspective. So, and anything, if you go higher in the scale, it means it's environmentally bad for you. In other words, it has more of an impact on the environment. So this side, this is where you want to be. This is the sweet spot, right here. So you can look at that, nuts, legumes, whole grains, potatoes, vegetables, reduce your mortality, but also environmentally very less impactful. This is where you don't want to be. High impact, environmental impact, bad for you, increases mortality. And unfortunately, this flies in the face of our current nutritional guidelines, unfortunately, which no comment on that. So you'll have to talk to me outside of the venue. But on the right side is greenhouse gas emissions. And the way I frame this is, look, nobody's asking you to make special contributions to climate emissions. I mean, no. But do what's good for health. Do what's good for your cardiovascular health. What's good for cardiovascular health oftentimes has a lower environmental impact and lower emissions. Very easy. Eat less, walk more, try to avoid fossil fuel sources if you can. I mean, if you have to, in California and Los Angeles, you got to drive sometimes to get to work. There's no escaping that. So, of course, do that. But wherever possible, try to reduce your footprint. But it's also good for your heart. So it's very easy, to actually lead an environmentally responsible life as long as you're cardiovascularly healthy. So just do that. You don't have to believe in any of the political nonsense about climate, but just do what's good for you from a heart perspective and be selfish. Anyways, okay, but it's important because to change food systems is going to take a lot more than a couple of doctors speaking about this at a conference. This is a massive ecosystem, right? Multiple stakeholders, trillions of dollars, not billions, trillions of dollars at stake, right? And these people are just not going to walk over and let things happen, right? So how do you get them to a framework? So you've got to change policy. You've got to change the way food is made. You'll have to incentivize people, because at the end of the day, it's all about incentives. And it's about behavioral incentives, okay, to change behaviors. It's about policy economic incentives so that you make this worthwhile for people, right, to change to a different system. So how does a meat manufacturer, what are they going to do? Like tomorrow, you got to do something. So create incentive, and it's possible to do that. Unfortunately, I think the United States has abdicated their premium position on the world stage to make these types of changes from a standpoint of innovation and transformation. And what I mean by that is green technology, measures in which you can transform ecosystems, but also transform economic systems to make it monetarily worthwhile. This is where I don't understand, the current, and this is the only political statement I'm going to make, because it doesn't make any economic sense to me, where you could shift to a different model where you incentivize people, make lots of money, and this is, after all, the US of A, and get rich. And there's a way to do that. But anyways, but you got to transform this. I'm also going to talk about green exposures, because this is important. This is, I think, a very poorly appreciated, but cheap and very effective intervention for health that people underestimate. Okay, and that's greenery. And I'm showing you this because this can be measured. Greenery can be measured with satellite technology at a 20-meter resolution level across the globe. So I can get you green exposures and know exactly how much of greenery is around your house to tell you how much of greenery you're being exposed to, right? So you can do that. It's measured using this technology, satellites called NDVI. There's tons of papers showing that higher greenery is associated with lower levels of heart attacks and mortality. Now, I'll be the first to admit there's a lot of confounders. So you could say people that live close to greener areas are probably wealthier. They take care of themselves. They do a lot more physical activity. Yes, of course, all of that stuff. But there might be more to this, right? So this is just some you might not be able to see this at the back of the stage here, but essentially it shows you this side of this line is good. So it shows you the green exposures are good for you and reduces mortality. Now, there's something in Japan called Shinrikyo. And I don't know how many of you know this. This was introduced in the 1980s as a practice where you could go inside a forest. It's called forest bathing. But it's supposed to be a very sensual experience, because you're supposed to pause as you're walking through it, and you smell, you touch. It's a very sensory experience. And it's very popular, by the way. And you can pay some of these forest bathing experiences, you have to pay money for it. So they actually charge you for it. But this is the way we're going, right? You have to check into a luxury hotel with no Wi-Fi connection, and then you pay $1,000 for that. So this is the same kind of experience. They charge you for a sensory experience in the forest. You can do that for free in the Santa Monica Mountains somewhere, right? So, anyway, but this is good for you, it turns out. And previously we used to say, well, the benefits of green space are because of mental mindfulness. You feel relaxed, you walk more, right? And there's, very calming effect of greenery. But it's much more than that. It's much more than that. People are starting to recognize, this is a very interesting experiment. What they did was to take 11 individuals, had them walk around in a forest, and this was done, I think, somewhere in suburban Kentucky, which is where Dr. Bhatnagar lives. And what they did was they measured their blood levels to find chemicals that are associated with, and this is called limonene. Limonene is actually it's a very potent aromatic chemical that's released by greenery. And you can actually measure this in the plasma. So if you're exposed to these greenery, you actually are exposed to these volatile chemicals that you can measure. And there are thousands of these. We're just not measuring them. It doesn't mean that they don't exist. An example of this, where you can measure limonene, so you can see limonene go up in response to a green exposure. That's pretty darn interesting, right? So many of these chemicals could have very salutary effects in your brain, how you feel in general, and in your cardiovascular health. But more on this later, but this is an emerging area of science, of environmental exposures. Now, we now get to the point of what do we do all about this? And this is a question that I often have. It's like you're talking about all these, planetary scale exposures, and what the hell am I supposed to do? I'm just a single guy in a clinic seeing 50 patients, doctor, and you're telling me I'm supposed to discuss all these environmental exposures? So give me, what do I do? So this is a slide for those of you, to at least have a conversation with your patients about this. The first thing to appreciate and understand is that many of the chemical exposures and environmental exposures are not even known. So it's what I call, to use, who's the guy who came up with the known knowns, unknown unknowns, and the known knowns? Don Rumsfeld, right? So remember Don Rumsfeld, right? So Don Rumsfeld, so zone 1 chemicals are the known knowns, and you can see many of these exposures: noise pollution, air pollution, things that we know. And then there's emerging signs, emerging factors, or known unknowns. And then you have the unknown unknowns. So I'm just talking about zone 1 now, the known knowns. And what can you tell your patients about it? Well, what I do normally, because I do, have a busy clinic as well. So I start with traditional risk factors. You deal with what you know. At least do your job in terms of making sure that patients' blood pressures are controlled, the diabetes is controlled, they're on the right medications. Talk to them about what they can do about physical activities. Maybe, even discuss some of the emerging risk factors like Lp(a). There are things and a lot of science in these areas. So you talk about some of the emerging risk factors, and you can ignore everything else. This fine print you can ignore. So focus on the traditional risk factors. Think about emerging risk factors. Optimize them. Try to do your best in lowering them, because that's your best bet. And then in the odd patient who comes in with, persistent cardiovascular risk or residual risk, or people who are recurrent events, it might be worthwhile thinking about some of these environmental exposures, right? I think in the future, it might be much more easy through the use of artificial intelligence and machine learning, where a patient fills out that we are developing, and I'll show you some of the tools that we're developing might do all the work for you. So I don't have to engage in doing a complicated environmental history, right? So AI and machine learning might solve some of the problems. So once you do that, in these patients, you would figure out whether they have additional conversation. In California, it might be worthwhile talking about where you live, whether it's close to wildfire exposures, whether you live close to a highway, and those types of things might be important. If you happen to live in the southwestern United States, a conversation about arsenic and lead might be appropriate. Midwest, I talk about lead in especially some of the communities in Cleveland. And then employ environmental risk mitigation strategies with things that you know to do and where there's science. What do I mean by that? One is, in this part of the country, if you happen to have risk factors, going back to our patient vignettes, patient with risk factors for heart disease, might be worthwhile to talk about protective equipment. Things like indoor air purifiers, and certainly in places of the world like New Delhi or Beijing, it's a necessity where you have indoor air purifiers that lower your air pollution levels, right? And there's good evidence suggesting that this is good for you. Even if you lowered air pollution levels acutely with an indoor air purifier or an N95 mask, you can actually change blood pressure, you improve endothelial function, you change heart rate variability, you change PI1, which is a thrombotic marker or high levels sticky marker, and reduce inflammation. And the evidence suggests, and this is a meta-analysis of at least 17 studies, randomized controlled clinical trials. So people have done randomized controlled clinical trials with air purifiers and shown that when you use an air purifier, it lowers blood pressure. No question. Okay, that I can tell you. And this lowers blood pressure. If you lower particle concentrations by 60%, you can get approximately a 4 millimeter reduction in blood pressure. In a marginal patient, that might be worthwhile doing. So I think I do recommend this. If you happen to be infirm, if you're taking immunosuppression, if you happen to have other comorbidities, it's worthwhile protecting yourself. For the average person who has an acute wildfire episode, may not need to take these steps, but there's a lot of confusion in this area around what type of protection equipment you need to take advantage of, or what you need to do. And hopefully that will change through better guidelines and better recommendations. So this is something that we'll put together for the American Heart Association. It's a little busy, but right at the center you see comorbidity special demographics. And what I mean by that is if you've been in the hospital if you've been hospitalized, if you have heart disease, stroke, if you're high risk because of other reasons, those individuals absolutely need to be protected. And you can follow this algorithm where you take extra measures. Extra measures include avoiding those high pollution areas, wearing an N95 mask if you were to go out, using an indoor air filtration device, even looking at modern air conditioning systems that lower your exposure levels, right? And if you happen to live in a chronically exposed environment, like you happen to live in New Delhi, absolutely, I think you should talk about taking steps to reduce your exposure over time. Okay, now the problem is exposures don't occur in isolation. And I talked about this right at the beginning, right? So I talked about environmental exposures in two individuals, one with social factors, right? And social factors are big. Economic disadvantage is a big one. So there are fundamental challenges here, and the challenges are here, including the long latency period, et cetera. So I'll skip this and get to the meat of what I'm about to leave you with in the last 5 minutes. I'm almost done here. And that is an exposomic view of health, where we put these factors together, and we are in the age of AI, where we can take all of these factors together and use AI models to come up with a fingerprint of what your exposure levels are. And that's where we're headed towards. And there's tremendous opportunity in this area. This is what I call exposomic view of health, or a risk in person, time, place, context. So in other words, you have an understanding of where you live, what your exposures are in those areas, and put together a much more comprehensive view of your health rather than the relatively, restricted lens that we currently use to define your exposures. And a good example of this happens to be in Cleveland. I live in a neighborhood called Shaker Heights, and Van Aken Boulevard is a boulevard that divides, you just walk a few feet on the other side and you're in a low income neighborhood. And this side of it, home values are much higher. I'm sure LA has those areas on steroids. I mean, you have many areas that abut each other where you have such incongruence, shall we say, in socioeconomic status. And this happens to be a very important predictor of health. You've heard this aphorism, your zip code is a better predictor of your health than your genetic code, and that's true in many parts of the United States, right? So, and here you have the US map, where it shows you dark blue areas that are socioeconomically deprived areas, a lot of it, unfortunately, in the southeastern United States, but certainly the South, in Texas and parts of California, you have major disparities, and that's a very, very good determinant of health. Just living in those areas, high levels of mortality. And you see that here, where it shows you that higher the levels of SDI, and SDI is something which is an economic index defined as people living in poverty, and that's a very important predictor of health. So economics actually are baked into this. I'll skip this because it just drives home the point that people in the United States who die prematurely because of heart attacks have the same kind of factors that also drive obesity, right? In the bottom, you have obesity, and you look at it and go, well, those are the same areas, right? Same areas. And the same drivers, these are all the same things, right? Economics, poverty, living in crowded households, living close to highways, all kinds of things, and they're the same factors. So we have a number of these things where we can use to define the environment, and the way we do that is by using tools like this, where we can actually take pictures of your home, Google Street Views, and we can do this across the world. I could take Google Street Views, extract the features using AI, and I have instantaneously all your physical built environment. I also can take satellites to gather exposure data. The air pollution stuff that I'm talking about is all through satellite data. So I can get very good information on a number of chemical exposures through satellites, right? I can put this together in a model, and this is shown here. So it's very complicated. I can also take your genetic information, put that together in a model, and use that and use a variety of AI techniques. And this is sort of an AI neural net to use that to predict your survival. Prognostic meaning, is it going to be good for you, bad for you? Diagnostic, and finally, what was the other one? Prediction. All right, so this is one paper that I'll just show you where we did this across the United States and in multiple cities. And this is done in 7 cities, as you can see here, like Detroit, Cleveland, Brownsville. I don't think California is here. Or Fremont. Yeah, Fremont is actually an outlier because very well educated, as opposed to Cleveland, Detroit, which are industrial cities. So Fremont is actually put in there to reflect a modern city with educated populations and living in a good environment. But you can see that when we use the AI model to predict, this is the actual CHD as coronary heart disease, actual, and this is the predicted. And you can see all of them, the prediction performed very well. And we can also figure out what features in the street view is contributing to heart attacks. And it happened to be areas that are not very green. The green is actually good for you. A lot of pavements are not so good for you. So it can actually predict some of the features in the Google Street Views that correlate with high mortality. This is my final slide. I think, from a global perspective, I think all of this has a lot to do with policy. And there is a lot of synergy between drivers of climate and drivers of cardiovascular disease. So they are the same problems that cause cardiovascular disease that also drive environmental exposures and climate change. So this is what I call convergent cardiovascular solutions. So it's a win-win for heart health. It's also a win-win for the environment. So on the other hand, I think getting away or doing away with things like fossil fuel, but promoting green space, promoting renewable energy, local food production, less resource-intensive healthcare. These are all good things that can mitigate and improve cardiovascular health while reducing environmental impact. So I'll stop there. Thank you again for this wonderful opportunity. So nice to be here with you today.